Okay, why don't we go ahead and get started?
Aside from that.
Yeah, so thank you all for coming down the tram to attend Steve's master's thesis defense. He's not got his wife here, so start. The program book yesterday at graduation says that just because you're in the book doesn't mean you graduate. So even though the book says that Steve has his master's degree, he actually won't have it until he successfully defends his thesis and then submits his write-up, which I'm confident he'll do in glowing manner because we've already signed him to a contract to join the faculty of OHSU and DMICS anyway. So
congratulations to both of them.
So anyways, I think everyone knows Steve. He's a postdoc fellow on the NLM grant. He received his MD from Brown University in Providence, Rhode Island, and then did his internal medicine residency there and served as chief resident. I remember getting an email from Tom Cooney telling me about this great candidate for our fellowship program about 2.5 years ago, and I think that turned out to be the case. And so Steve has come. He's done the master's degree and is defending his master's thesis today on the topic of clinical decision support. He's also active in clinical decision support, a role I assume he'll continue in some capacity with the Clinical Decision Support Committee in the hospital. So, as always, Steve will give his presentation. We'll have a public presentation. Public can ask questions. We'll all be dismissed, leaving behind his committee that may ask further questions. Then he leaves, and his committee decides whether he passes or not. If he does, then he still needs to finish his write-up. So, take it away, Steve.
Okay, thanks so much, Dr. Hirsch. I appreciate the introduction. Thanks, everybody, for coming down and hearing my talk today. I got a few, as many of you know, I'm fairly close with Alfredo Almarares, who's a former postdoc here, and he sent me, a whole flurry of messages through WhatsApp and said, "Oh, you got to say something funny. You got to show them these funny videos." And all these videos he showed, I just thought, "Oh my God, I'd be so embarrassed to show these videos." I can't do that. So anyway, maybe that'll be the funny thing is talking about it. So the title of my talk is Clinical Decision Support Malfunctions, and obviously we'll sort of talk about definitions quite a bit. But I thought it was helpful up front to just sort of explain clinical decision support, what it is, and malfunctions, what those are. So clinical decision support is really about giving information or knowledge at the point of care to help improve outcomes. And malfunctions, I'm going to sort of loosely define at this point as just sort of errors or when the system breaks. So a little roadmap about what we'll talk about. We'll talk about clinical decision support, some of the background work that's been done on it, some work on anomaly detection and malfunctions, and then also talk about clinical decision support malfunctions, which is the sort of meat of what I'm going to talk about today. So what's the motivation for this work? And it's really that a lot of the clinical decision support tools that we have, they can break, and we don't really have a method or a framework to detect them. So the example I'm going to show here has to do with heparin. So heparin's a blood thinning medication that's used fairly commonly in the hospital. It's used for deep vein thrombosis, myocardial infarction, and a number of other things. Has a fairly narrow therapeutic window, meaning too much of the medication, you can get a life-threatening bleeding event, or too little and it doesn't work. So it's really important that when heparin's being used, that there's associated orders to monitor it in place. So those orders sort of tell the nurse how to titrate it, and they also dictate how often labs should be drawn. So what I'm showing right here is a figure from how often a clinical decision support alert fires related to use of heparin. So the way that this alert is set up, it basically looks, and if a patient has orders for heparin, it checks to see that they have these associated orders to do the monitoring and the safety. If it doesn't, the alert fires. So just real briefly to explain this figure, and this will actually be sort of an example of many of the figures that I'll show. They're all time series, so often this one in particular is sort of bucketed into months at the bottom. And then alert firing rate is the number of times this alert fired per month. You can see when the alert came online, February was going about 150 or so, and then sort of evened out around 250, 300, and then it dropped off. So why did that happen? Currently, we don't really have a good framework to understand that, or even a system to detect that. Is that something that should have happened? Was there a change in the workflow? Did something change in the way that heparin is ordered or the way that it's administered? And we just don't really know. So that's sort of what's sort of the motivation for the work. And at this point, just to sort of get a little bit into the definitions, I would call this an anomaly. So this heparin alert it's not functioning as we expected or as expected or consistent with its past historical pattern. I can't say it's a malfunction. I don't know if it's broken yet or not, so we'll talk about that a little bit more. So what about clinical decision support? So as I said before, it's really about giving sort of knowledge and information that's person-specific, filtered at the point of care to help improve outcomes. There's a number of different frameworks for it. This is my personal favorite one called the 5 Rights that was developed by Jerry Asheroff and some other colleagues. So the first piece of the 5 Rights is the right information. So you want it to be evidence-based, you want it to be pertinent, actionable, you want it to the right person. Okay, so oftentimes in a sort of physician-centric world, we're always thinking, oh, it needs to go to the physician, but in other situations, it may actually be best delivered to the patient, maybe someone else on the care team. And what's the format? A lot of what we're going to talk about today relates to alerts, but there's a lot of other clinical decision support out there. There's order sets, flow sheets, data visualization, and what about the channel? Today's talk will focus on the electronic health record, but sometimes maybe through mobile devices, through patient portal, or, dare I say it, sometimes on paper might even be the right thing. And then we also want to have it at the right point in the workflow. So if you're thinking about something related to some medication interaction, you probably want to have that as upstream in the workflow, at least at the point of ordering or at the point that someone's thinking about ordering, not at the point of, of barcode administration or something like that. So clinical decision support has a fairly long history. Its sort of seminal paper was back in 1975, was a paper that Clem McDonald put together where they had a system where they basically took for about maybe 50 different sort of care scenarios, and when those came up, looked through the patient's record and provided recommendations to the providers. And what they found in a crossover RCT was actually that providing that information to the providers improved the process-related outcomes that they were looking at. So a lot of clinical decision support trials have been done since then. There have been a number of different systematic reviews. The first one by Kawamoto was mostly confined to academic centers using homegrown systems. Really looked at just process outcomes and didn't find anything more than that, but what did improve those process outcomes. A couple of features that were associated with clinical support systems that worked, and this is what sort of feeds into the 5 Rights framework that I talked about before. Having it be at the right point in the clinical workflow, having it be associated with the time and location of the decision making, using recommendations, and also having it be computerized. The next systematic review really showed the same things. Again, process outcomes, mostly internal systems that were developed in academic settings. Then in 2011, finally there was some data outside the academic settings and in commercial systems, and found that they were able to improve some clinical process outcomes. And the most recent one from 2014 looked at just RCTs related to clinical decision support, and they looked at mortality, morbidity, and some economic outcomes. Found there was no effect on mortality. There wasn't a statistically significant effect on morbidity, but no effect on economic outcomes, and that included commercial systems primarily. So clinical decision support has a lot of different forms. This work, the taxonomy that I'm going to sort of talk about was actually one that was developed by Dr. Adam Wright, who was the first PhD graduate from the program. So the first part of it is medication dosing support. So that could take a number of different forms, but if medication's dose needs to be dosed based on weight, based on age, kidney disease, adjusted for liver dysfunction, anything like that, maximum daily doses, those things could be implemented into a system. And just to sort of give that a little bit of a story, there's a case report as recently as 2011 for a 6-month-old that had a fever and a cough and was brought to the emergency room. The patient was diagnosed with pneumonia, given azithromycin, which is a reasonable medication to be given. The patient received 500 milligrams, which is an average adult-sized dose, about 10 times what the child needed. The hospital where the patient was seen didn't have any clinical decision support in place. The patient got the 500 milligrams, ended up having a cardiac arrest, and unfortunately died. And that's something that people feel like generally, could be prevented through clinical decision support. Other systems or other parts of the framework, order facilitators are fairly common. I know that's sort of hard to see. Those are most commonly seen as order sets. So oftentimes for a lot of different diagnoses in the hospital, there's a fairly routine set of orders that the patient will get with some wiggle room for dosing and things. And the idea with this is you want to have the order set already set up so people can just pick the things off it that they commonly do and don't miss the one that they need. Information display is another one. This is demonstrating, showing the pricing of various lab tests and how that would inform decision making. And then expert systems. This is just a cartoon. patient sitting there with the doctor. If you can't read the bottom, it says, if you want a second opinion, I'll ask my computer. There's a number of different antibiotic support, ventilation management, diagnostic tools, prognostic tools that fall into that category. The final two pieces of Adam's framework, the top one is about workflow support. So that's about order routing, registry functions, medication reconciliations. The figure that I'm showing you up here is from Twinrix, which is from a group at the University of Maryland. So they've focused on creating this workflow support tool for medication reconciliation. Medication reconciliation is the act of sort of looking at the different lists of medications that the patient's taking at a certain point in time, trying to find out what they're actually taking, what they should be taking, and then have them try to be taking what you want. And the idea with this is for a transition period in the hospital. So you have intake unique, which is what they were taking that's unique on the way in, intake similar medication you have in the hospital, medications are identical, and then unique in the hospital. And the idea is sort of try to bring all that together so you can appropriately discharge them on the medications. And the last part of the framework is alerts and reminders. And these are can be fairly broad, but essentially they're about the idea of combining either medication, condition, physician attribute and condition, so a whole host of different things, and they're pretty flexible. And they're sort of presented either as, oftentimes as sort of intrusive, sometimes pop-ups within the workflow, and that's sort of what we'll focus on today. However, clinical decision support, the studies that I talked about, they always sort of examined clinical decision support in isolation, not in the totality of the whole system, and it's a much more complicated thing in real-world settings. Most places have a pretty high volume of alerts. A lot of people feel like those alerts are not, oftentimes probably have more false positives, and they're maybe a little bit more meaningless than they'd like. And there's this phenomenon of alert fatigue, which I'm sure many of you are familiar with. So a lot of the settings that people have looked at alert fatigue, it's mostly related to drug-drug interactions, but almost 50, in some studies 50, and as high as 96% of those alerts are overridden. And oftentimes there's very little effort made to prioritize the alerts. Meaningless ones are really shown right alongside ones that could be life-threatening or critical. So sort of as the background of the work that I undertook, it's thinking that it's really important that the clinical decision support that we do put out there needs to be high quality. We need to make sure that we monitor it and understand what it's doing, because if we just sort of push it out of the nest and let it fly and have no idea what it's doing, it's really going to contribute to this unfortunate consequence that is alert fatigue. So knowledge management surrounding clinical decision support has always been a very resource-intensive activity. So this is one of my favorite figures that I ever saw in a journal. So it's from the British Medical Journal in 1998. So what the authors of this study did is they went around to maybe about 60 primary care practices, and they said, we want to have give us every guideline that you're supposed to be implementing. And what they did is then they stacked it up. There was 855 of them, and it was some 70 centimeters high and weighed about 30 kilograms. And you could imagine how astronomical that's grown, and some work that Dr. Ash has done in our department showed that keeping current on the content for clinical decision support is really one of the major drivers for some of the unintended consequences of CDS. And when I think about the knowledge management piece and sort of managing CDS, I sort of think about it as three parts. The first is making sure the content's valid. So if it's something that's guideline based, do you have the most up-to-date guidelines? Are the guidelines actually, are they valid? And then the next piece is sort of technical validity. Is the CDS doing what you want it? And that's really where the focus of my study is going to come in today. So is it performing as intended? And then efficacy is sort of the holy grail. Is it actually doing what we want? If we're giving clinical decision support so people stop ordering so much blood, are they actually not ordering as much blood as we want them to? Or are they ordering as much blood as we want them to? So most of the clinical decision support that we sort of manage here at OHSU is what I would call rule-based. So that has a trigger. So there's some event within the electronic health record that says, okay, we're going to now trigger this event, and we're going to go look through and see if this patient and their criteria sort of match this clinical decision support rule. And then the input data elements can be anything from, attributes of the patient, the diagnosis, the time of day, the setting, anything you could really think of. And then the intervention in this case is going to be, an alert, and then offer choices can be any host number of things. And really you could think about these type of rule-based ones as really kind of simple or in some cases complex if-then statements. So if you have condition A and condition B, or if you have condition A and medication A, then show alert X. So one of the, just to sort of flesh this out a little bit more, I'm going to show you one alert that I've actually done a little bit of work on outside of this study. So this is an alert related to overuse of red blood cell transfusions. So for those that aren't familiar with it, we've been really marching back on how much red blood cells we transfuse to patients. We used to try to just transfuse them until we could get the numbers high as possible, and found out that we were probably doing a lot more harm than good with that. So we've really kind of marched back on that. So most of the guidelines say really if patients aren't symptomatic that you probably shouldn't transfuse them for anemia until their hemoglobin is less than 7, or in this case, equivalent hematocrit of 21. So with this, the way that this one works is we go ahead and when there's an order for red blood cells that's placed in the system, this rule is then triggered. It looks at the patient's most recent hematocrit and some attributes related to the patient because it doesn't apply to all patients. We're just using it on inpatients. Some of the inpatients are excluded. If they meet the criteria that we want, we go ahead and we present this alert. And then at the bottom, what you can see is with those buttons at the bottom sort of provide some different reasons that they may override the alert if they feel it's not appropriate to follow that recommendation. So when you have a clinical decision support rule like this, you might think that there's a number of different ways in which the rule could actually break down. So this system, when we go ahead and build it, we use hematocrit and we use the code for hematocrit and we sort of burn it into the clinical decision support system. But there is the possibility that the lab who ultimately controls the way that hematocrit's done and studied may choose to do it through a different way, and they have all of a sudden they're implementing it through a different mechanism, and then that doesn't get passed back to us, and all of a sudden all the hematocrits that are being done in the hospital are using a different lab code, and that's one way. There could also be attributes about the patients that are somehow different, or the patients being described differently, or the providers being described differently within the EHR. Has the workflow drastically changed in some way that we didn't capture, weren't aware of it? The decision support could just malfunction. So I want to talk a little bit about some work, the amount of work that's been done on clinical decision support malfunction so far. So this is work from Adam Wright, who I mentioned developed the CDS framework and is a PhD graduate from here. So about a month and a half ago, they published a 4-case series of clinical decision support malfunctions. So they looked at clinical decision support malfunctions from their homegrown EHR, which they just recently transitioned off of. And they started with an alert cohort of about 200 or so. So the figure that I'm going to show you here is related to pediatric lead screening. So probably if you didn't know something about pediatric lead screening, they've recently learned about it with everything that happened in Flint, Michigan, and is now happening in Portland. But essentially, lead is a neurotoxin. It's particularly damaging in the developmental stage of life, so there's universal screening guidelines that children, I think, age 2 through 5 should be screened for lead. So this clinical decision support rule that they had in the outpatient setting basically would look at a patient. If they were over 2 and didn't have a recent lead screening, it would send an alert to the provider that they should do this care for the patient. So in this figure, what you see across the x-axis is the date, and the y-axis is the number of firings per day. The light blue, I think that's light blue, I'm colorblind, and the black, I'm pretty sure that's black, still colorblind. Light blue is weekdays, black is weekends. So what you see basically is until, when the alert was firing, it was going about maybe 200 to almost 400 times a day, and then basically in 2009 just dropped off and didn't have any activity until late 2011. When they went back through and tried to figure out what actually happened, they looked through the alert itself, and someone had gone back in, or an analyst had gone back in and added 2 additional clauses to the rule. So the rule now, after the analyst did this, the rule looked to see what the patient's smoking status was and the patient's gender. Now, even if you could conceive that you should be asking 2-year-olds what their smoking status was, it essentially didn't matter, because when it was done, no one, the clauses, what the answers should be were never put in there, right? So it just said evaluate smoking status, but it didn't have a yes/no for it, and so the rule by default when that happens in their system, it always defaulted to false. So best they could tell, someone went in, started editing this rule, maybe realized they weren't supposed to be doing it or was in the wrong rule, but never went back and fixed it. The 3 additional CDS malfunctions that they identified, one was what I talked about as a possibility before, which was a change in the lab code related to thyroid stimulating hormone. They also found just sort of a general system-wide software update that they performed that caused a massive increase in the number of alerts that were happening, and that was caught very quickly. And then the 4th was related to third-party content. So most healthcare systems use third-party vendors to provide the medication information, and they had an error related to that. But within the commercial vendor EHR sphere, no one's really looked at this yet. So the data that I'll present will be some of the first stuff that's been done. And within the commercial electronic health records, there really isn't much of a mechanism to monitor the clinical decision support, and we really don't have much of a framework to really detect it. And that's really the focus of what I'm going to sort of hopefully impart on you today that I did. So moving a little bit into the method, so anomaly detection, which is one of the underlying methods that I'm going to use in here, it's used in a lot of different fields: credit card fraud, banking fraud, computer security, industrial processes. Anomalies known by a lot of different names: outliers, exceptions, oddities, surprises, and they all talk about sort of trying to find patterns in the data that we didn't expect or didn't conform to prior behavior. It's a little bit different. Most of us are probably familiar with sort of statistical outlier detection, where you basically want to find the data that doesn't make sense and just get rid of it. But the idea with anomaly detection is the data that doesn't make sense or doesn't conform to prior patterns represents something. It represents some real-world event that you hope in some way is actionable. And anomaly detection, I sort of think about, it doesn't have any judgment on it. It's just saying, this doesn't conform to what you'd expect. Whereas malfunction, which is the term I'm going to use, is really talking about, this rule or whatever it is doesn't function as you designed or expected, i.e. it's not working. So visualization is kind of one of the primary methods of anomaly detection. So the example I'm going to show you here is related to influenza-like illness. So influenza-like illness is exactly what the words say, which basically is when you have someone who has an illness that looks like influenza. The CDC uses this, not quite a diagnosis, but this sort of categorization to help inform their influenza modeling for the year in outbreaks. So I've just sort of created some fake data here, but hopefully can get the point across. So this is a time series graph. So on the x-axis you have the months and 6 months increments, and then on the y you have the number of ILI cases reported. So what you see, and again the data is made up, so try to just imagine how beautiful it is. So there's a spike in the winter time, and then it sort of drops off in the summer, and the spike in the winter time goes up to about 20 cases, and you see that. The single point that I've highlighted is there's 18 cases of influenza-like illness. Now that in the data set, it's not necessarily abnormal, but in the context of it happening during the summer is clearly abnormal and is a contextual anomaly. And the idea is, the data, you put it in a form when you visualize it to help the expert user sort of go through it and make that assessment. But the data itself isn't actually all that informative without the visualization. Another method is statistical process control, and it's particularly useful for time series data. Statistical process control requires that the outcome of interest is sort of in a steady state or has some level of variability that you can manage. So what is happening here? So this is a figure where I create a statistical process control chart. So this is an alert related to patients and what their HMO is. So you can see it fires approximately, anywhere from 30 to 70 times a month. So with a statistical process control chart, what you essentially do is you create an average line in aggregate over what you're looking at, and then you can create upper control limits or lower control limits. And you can adjust those control limits depending upon how sensitive you want your test to be. Or how specific. In this case, these are 3 times standard deviation. And then there's a number of different formal tests that you can use to say when it's sort of out of bounds of what you'd expect. So the objectives for the research that I undertook were firstly to determine whether there were CDS malfunctions occurring in a commercial EHR. Secondly, characterize the pathways that were leading to those malfunctions, if I found them. And then describe methods of detection and prevention for those malfunctions. So the methods that I used, so the alert cohort came from OHSU, which is a 576-bed tertiary care facility. The electronic health record we're using here is EPIC. In the electronic health record here, the alerts are known as best practice advisories. Not all best practice advisories sort of are alerts. There's some other processes that we use them for, but mine are confined to alerts as I described them previously. All the alerts that I examined here are under local knowledge management and implementation, so none of this is third-party content that we purchased. This is all things that we as an institution decided to implement and then are responsible for managing. The alert cohort's from a 5-year period from 2010 to 2015, and I restricted the cohort to active and visible alerts. The primary outcome that I looked at was the number of malfunctions and unclassified anomalies per alert month. An alert month is essentially the number of months that alerts were active. So if you only had 2 alerts, one was active 3 months, one was active 5 months, you have 8 alert months. We have a few more than that, though. As for the data abstraction and refinement process, so for those of you that don't know, in the EHR, the production database isn't really usable for any sort of analytics because of its hierarchical structure, so it undergoes an extract, transform, and load, and gets put into relational tables. I wrote SQL queries to those relational tables to create the data set, and then did some refinement work within Stata to get the final data set. The visualization, essentially what I did is I created data visualizations for all the alerts within the cohort. I applied my knowledge regarding clinical decision support as well as the specific clinical domains that were there, and then categorized the alert firing history as either anomalous or not. Again, anomaly different than malfunction. Anomaly being doesn't conform to historical patterns or expected. Malfunction not working as intended. And to make this a little bit clearer, to make the visual, I'll just take you through 2 of them. So this is an alert related to patients with diabetes needing A1C. So if patients did not have an A1C within the last 6 months, the provider who was seeing them in the ambulatory setting would get an alert. So this is, again, a time series plot. This is monthly to make it easier to visualize the number of alerts on the y-axis. So you see that it starts maybe about 1,600 and then goes up over time to about 2,000 or so. You know, there's a slight difference there, but that likely is the result of sort of just increased number of visits. So I did not call something like this an anomaly. In comparison, this is an alert. We'll talk about it in depth a little bit more related to a medication, enoxaparin. That's fairly similar to heparin, a little bit different. This alert doesn't quite fire as much, but you see when it started, it went about 30, 40, 50 times a month. There was a little bit of a spike and then dropped down to single digits, and it continued in that place for another until I found it, basically. And this was considered an anomaly. So yes, anomaly on this one. Following that, once I had the visual anomalies, I went through and I validated them. So the validation part was to define whether they were malfunctions, the CDS was not working as designed or intended, whether it was a false positive anomaly. And the false positive anomaly, it's anomalous, meaning that it's not conforming to historical patterns expected, but it's not actually broken. Something that we intentionally changed, either within the CDS world or a workflow change. There's something to explain it that it's actually, the CDS is still doing exactly what we wanted. And then a third category, which is unclassified anomalies. So that's sort of the unfortunate bucket that things get put into when, through the validation process, I wasn't able to sort of determine what that was. And what the validation process sort of looked like is, you know, I would start with the CDS rule, look at it. There's some timestamp data on there as far as what got changed when, speak with the analysts. In some cases, the analysts are still employed at OHSU. We have some change management logs that we keep for the CDS, as well as when there's changes within Epic as a whole. And I had access to all of those. I'd speak with the clinical owners, so if it was an alert related to psychiatry, I'd speak with both the psychiatry Epic analyst and speak with the psychiatry folks who sort of wanted that piece of CDS implemented. And then as needed, if it involved pharmacy or laboratory, I'd speak with those respective informatics folks as well. For statistical process control, that was applied to a subset of the alert cohort when appropriate. So as I mentioned, to use statistical process control, it needs to be sort of in a steady state, meaning you need to have a reasonable level of variability to it to be able to apply it. So not all the alerts was that applicable to, and we'll talk about that a little bit. And I used count charts, and that required an assumption of stable denominators, which is probably reasonable if your denominators aren't changing more than 20%. The test that I applied when using statistical process control, so a single point outside 3 standard deviations, control limit line, 2 out of 3 points greater than 2 standard deviations above the average line, and both those points on the same side, 8 or more points on one side of the average line, or 6 or more points steadily increasing or decreasing. Once I completed the statistical process control anomaly detection method, I then calculated the performance characteristics of it. So as many of you know, accuracy alone isn't really a sufficient classifier when you're looking at things that are anomalous or rare, because you can just say everything's normal and then you can be 99.9%. So to do this, I calculated the sensitivity, the positive predictive value, and the F measure. There's no gold standard for the data set that I have. So what I essentially did is I took statistical process control, used that to categorize the subset as either anomalous or not, and then I used the visualization classification as the gold standard for that. The idea or the possibility of validating the entire cohort is pretty much resource prohibitive because of the amount of time it takes and the ability to actually do it. So jumping into the results, so there was 226 active and visible alerts that I examined that represented a total of 8,300 alert months. Subsequently, applying visual anomaly detection, there was 21 visual anomalies. 4 of those were classified as malfunctions, 9 were unclassified, and 8 were false positives. So I'm going to walk through the 4 malfunctions because I think these are sort of important to spend some time on. So the first malfunction is related to enoxaparin. Enoxaparin is a medication similar to heparin. It's used for deep vein thrombosis, myocardial infarction, essentially as a blood thinner. Like heparin, it requires ancillary orders or accompanying orders to make sure that it's appropriately dosed and monitored. So what happened when this alert was created, it looked through the system to see that patients were on heparin, they had the appropriate medication, the appropriate ancillary orders done. So in this figure, what you see when the alert started, it was firing about 40 to 60 times a month, increased a little bit, and then eventually dropped down to single digits. So when I talked with the pharmacy informatics folks, as soon as I brought this to their attention, they said, actually this is kind of an error that we created. So what actually happens is with enoxaparin, the way they deal with some of the stuff that they create alerts around, they actually create dummy medication records. So when I, as a physician, go into the system and I go into the order entry screen into the formulary and I search for enoxaparin, it's actually a dummy order that's the one that's tied to the CDS. The real order for the medication is sort of hidden in the background. What actually happened was they were doing some routine maintenance on the hospital formulary list. The real medication record got sort of slipped back onto in the physician order area, and it wasn't intended to. This malfunction found it with both visualization and statistical process control. The next malfunction is related to influenza. So this is a little bit hard to see on this, but I'll try to sort of cue it into. So this alert, basically what it does is we found influenza vaccinations super important, can help reduce morbidity and mortality in a number of different groups, and is oftentimes a quality measure for a lot of hospital systems. So OHSU participates in a lot of those quality measure reportings and found that they were actually doing a good job with ordering the influenza, but actually administering it in the hospital setting turned out to be more problematic. What was happening was a lot of patients were being discharged before the immunization was actually given. So they created an alert that would display to the nurse. So for patients who had an active order for influenza vaccination and then subsequently had an order for discharge, an alert was provided to the nurse that said, hey, this patient needs to have this influenza vaccine given before discharge. So what you see, basically, when the alert gets turned on, because we activate it and deactivate it each year, it went off about 100 times a month and then sort of drops down as the influenza season wanes. There's nothing for the 2011-2012 influenza season, and then it comes back on for 2012, 2013, and 2013, 2014, and then it's gone for 14 and 15. And actually going back and speaking with the analysts, what actually happened was our CDS analyst who does most of this is responsible for sort of reactivating this each year. She was actually out on leave and passed these duties on to someone else, and they got missed. The third malfunction that I found is related to height documentation in the oncology clinic. So for most of the oncologic medications, they're dosed based on body surface area, so it requires accurate height documentation to do the medication safely. So the folks in the oncology clinic asked if they could have an alert created to be presented to the providers to make sure that if the patient did not have an active documented height within the last maybe 5 or 6 months, that one was taken and documented so they could appropriately dose the medications. So this alert, again, time series, months on the x-axis, number of alert firings on the y. When it came on, was firing quite a lot, 600 times a month, and then basically dropped down to 0. And the absence of dots implies that it's 0. So what actually happened was the way that the patients in this case were identified was at the department level. So there was a specific department that these patients were seen in. The departments within the electronic health record, as most systems use them, they're not really virtual representations of the physical world. They're sort of more entities to help push billing and scheduling processes. So they're often getting turned on and off quite frequently. This department just got retired. This type of change comes across in a change notice that happens when an analyst is doing work and they think what they're doing might affect someone outside their immediate sphere. It sort of goes into this epic change notice that OHS uses, but it's then left to the analyst on the other end receiving it to sort of open it up, look at it, think that it involves them, and doesn't always get through. The last malfunction that I have is related to coronary artery disease and medication use. So coronary artery disease is a ubiquitous chronic condition. There's a number of different medications, specifically the antiplatelet medications, which have been shown to reduce mortality and morbidity. So an alert was created at OHSU to essentially look and see if patients had coronary artery disease but did not have the appropriate medications ordered in an outpatient setting. The provider would be shown this alert. This alert was changed and additional medications were actually added so that the alert would be suppressed or not fire. But the way that it was done, actually an error happened and the alert started firing much more frequently till it was discovered. I want to show an unclassified anomaly just so I make that clear. So we just went through the 4 malfunctions that I found. So those were alerts that were not functioning as designed or intended. The unclassified were ones that I visualized or through statistical process control determined to be anomalies. The firing pattern didn't conform to sort of historical or expected patterns, but through the validation process was not able to classify it. So this is an alert related to second-generation antipsychotics. So second-generation antipsychotics are kind of ubiquitously used medication for a number of mental health conditions, both FDA-approved and off-label. They have a number of side effects, most notably some of their metabolic dysregulation. They can cause elevated cholesterol levels, so they require some level of lab monitoring. So the psychiatry department asked for an alert that would basically go through and look to see if patients who were on second-generation antipsychotics had appropriate lab monitoring. So time series again, x-axis is months, y-axis is the number of alert firings. So this, when you started off about 60 to 100 times a month, and then basically dropped down to this lower steady state level. So when you're going through this and talking with the CDS analysts and talking with the pharmacy folks, the lab folks, the psychiatry folks, the psychiatry analysts weren't really able to figure out why this had dropped down to the level it did. And at a certain point, I know to some degree you have to sort of take my word on this, but at a certain point, there's really diminishing returns with being able to actually determine why this happened. And we'll talk about that a little bit more. And then I do want to give one example of a false positive. So this is something that it's an anomaly, but actually is expected, or something that we, when sort of digging through and validating, actually makes sense that the firing pattern looks like this. So this is related to propofol administration. So propofol is a sedative. It's the medication that actually led to Michael Jackson's demise. And there is been a lot of shortages of the medication. So when there's a shortage, what happened is we created an alert that said, there's a shortage of propofol. Here are some additional medications you might use for this similar purposes. So what actually happened was, so this alert, when you look at it, it's going about 120, 160 times a month, and then there's these gaping holes in it. It turns out what actually happens is the way the pharmacy does this and does the maintenance related to the medication record, they, similar to the enoxaparin, they create a fake medication record. So during times of propofol shortages, when I go in and I look at propofol, the medication record that I select is actually just kind of a dummy medication record that then bounces out to this alert. So when the shortage is gone, they pull that record, but they leave the alert in place. So unless you knew that, you wouldn't necessarily know that there's no propofol shortage right now. But that's basically what those gaps are. There's no propofol shortage. So when looking at the performance of the SPC anomaly detection, so the SPC anomaly detection was able to be applied to 154 of the 226 CDS rules. It found 18 out of the 19 anomalies that I detected by visualization. 2 of the rules, so if you remember, there was 21 visual anomalies. 2 of those CDS rules were not amenable to statistical process control detection. And the sensitivity of it was 95%. Positive predictive value was about 29%, and the F measure was 44. So I want to add just a couple of quick notes about a couple of other things that I found that sort of wasn't looking for, but I thought were worth highlighting. So the alert that I mentioned before related to second-generation antipsychotics and lab monitoring, I mentioned how it basically stopped working. The psychiatry folks didn't know anything about it. Interestingly enough, in actually talking to them, they actually had about 3 or 4 months of effort into basically rebuild the entire same alert. But they really had no knowledge that that previous alert even existed or had died or anything, and they were basically trying to recreate the wheel with that, which is kind of a little bit of wasted effort. A similar situation with regard to HMO patients. So a certain group of HMO patients need to be admitted to a special clinical service. So when they get admitted, there's an alert that goes in place to make sure they get to the right clinical service. The older alert that we've had since 2010 was working fine, went off about 60 to 80 times a month for 2 years, and then just died. In trying to validate that, I wasn't able to classify that, so that went as an unclassified anomaly. But in doing the validation process, actually uncovered that someone had recreated the same alert 6 months ago. Speaking with those people, they didn't really know anything about the old alert. And then this may or may not be interesting, but the reason the new alert's working is identifying the patients as being members of the HMO by looking at who their primary care doc is and then seeing if they're on a master list of employees of the HMO, whereas the other old alert that doesn't seem to be working is looking to see who the patient's insurer and payer is, and that's sort of where the disconnect is. But anyway, in both cases, sort of duplicated it, and no one really had any knowledge that those old alerts had died. For some reason, people just said, oh, we need this thing, and didn't realize that they had it before, maybe. So to discuss some of the findings, in total, I found 4 CDS malfunctions and 9 unclassified anomalies in a total of 8,300 alert months. So I would classify all of the errors or malfunctions that I found as really knowledge management errors. So one was related to medication code maintenance. That was the enoxaparin one. The one related to influenza was about the CDS alert just not being activated. There was an internal code change for the oncology height documentation one when the department was retired, and then direct editing of the alert logic related to the coronary artery disease one. In comparison to the work that Adam did, Adam found, I think there's 2 pathways that are similar between his work and mine, which is the lab code change. I would sort of make that's pretty synonymous with, I think, the department change and direct rule editing. In their work, they had the third-party content that caused a malfunction, and then also global software, but I didn't really see that. So I think the anomaly or the malfunctions that I found, there's really no reason to think they wouldn't be in any implementation of commercial systems that are out there, because they're not necessarily related specifically to the commercial system we have. It's really about the knowledge management and implementation of clinical decision support. The 9 unclassifieds, I think, in a lot of ways represent, a lot more concern with the ones that I know what they are and I know what the pathways are. We can talk about ways to sort of prevent those and detect those, but the unclassified ones, it wouldn't surprise me if there's a number of different pathways underlying that, which may be some of why it's harder to validate it, but I think it's a super important group to look further into. And I think also it's likely, one of the limitations, we'll talk about it a little bit more, but is that this was done retrospectively. So when I would go to people and I would say, hey, do you remember March 12th, 2011? Maybe something happened that day that was interesting. Probably not, And so I think of it akin to, if you're looking for a needle in a haystack that you maybe dropped it 3 or 4 years ago and you're not sure, which haystack you dropped it in. But I think if you're doing this prospectively, you can sort of call back to whoever's involved and say, hey, yesterday this alert just stopped functioning. I think it'd be much easier for people to be able to recall what happened. So when talking about these findings, what are the ways in which I sort of approach it sort of as both prevention and detection? So what are the ways in which we can prevent this? It's easy to sort of throw up and say, okay, we're going to say, every time you change the system, it needs to be tested. And that, isn't really feasible. I mean, the amount of changes that are going on in the system are astronomical. I think, changes directly to the alert logic, yes, that stuff needs to be tested. But I think changes within the system are a little bit more complicated. I think one of the pieces is having a system that actually looks at some of the attributes. So the way that it works is, if I'm an analyst and I make a change in the system and I think it affects other people, I send it through this basically like kind of blast email system. But it's really complicated to actually try to look through the whole build and find out where is it that hematocrit's being used. Okay, if I'm going to change hematocrit at the lab level or I'm going to retire this department, it's probably better to do that almost one time or be able to map that through the system, but it's pretty awkward to do as it currently stands. And I think, if you're able to sort of create some system that is able to sort of automate it or track all those attributes through there, I think that would be much more helpful. Our knowledge management tools that we use in CDS aren't really tied into the activity of the alerts themselves. So we're using some Microsoft SharePoint products, which basically allow us to sort of communicate and keep track of tasks and lists and things, but they don't actually tie into what's actually going on. So when it's influenza season and there's 15 alerts that need to be sort of updated and turned on, that's just kind of, that's kind of on someone's task to-do list, but when it doesn't happen, we don't necessarily have a way of sort of spotting that. And then another piece I think that's important is the versioning. So we have, the way the system is, you can basically just overwrite everything. When you create a new record, you can just keep the same record, just keep overwriting it, which is what most of the institutions are doing for CDS. You can actually use versioning on that and track that out. And that would definitely be something to look into. And then I think also, as far as prevention, there's also other things that we need to consider when we sort of discover what those other pathways are from the unclassified group. As far as detection, the statistical process control method was able to be applied to about 70% of the cohort. I think a lot of that the limitation of that was sort of twofold. One, there's a whole host of alerts that aren't doing all that much, meaning they're not firing that frequently, and therefore it doesn't, if you have something that's firing once a week and then a couple times the next week, you can't really apply statistical process control to it. And then also you're sort of limited when you're doing it retrospectively. So if I do it retrospectively, I have to set an aggregate line for the whole group because I don't necessarily know when an intervention is actually coming in that would affect it. But if you're doing it prospectively, you can continuously sort of reset your control line when something changes that you're aware of. So I think, if you're able to run this prospectively, you'd be able to apply the statistical process control methods much more broadly and then probably just use visualization as a supplement to those that it's not amenable to. So some of the strength and limitations, so this work was done in the commercial system, which is really the standard that everybody else is using. Everything I did and used in this study is all commercially available tools, so anyone should be able to pretty easily replicate the work. One of the limitations, as I mentioned before, I use control charts, meaning it's just number of events per time, and so what that basically assumes is the underlying denominator is not changing. That's a sort of, I think, valid and necessary assumption. I think it's valid because, one, the underlying, the denominators, if they were changing significantly, would have to be rather large events, so outside of 20%. And the reality is, if you wanted to try to go back in and replicate each individual group every time it changes and try and plot those denominators, I think the reality is you'd probably introduce more error than any benefit you'd likely gain. Another limitation, as I mentioned, is sort of using aggregate control lines, which is just sort of the reality if you're doing this retrospectively. So I had to take 2010 through 2015 and just have a single average line. I wasn't able to reset the control limits for the statistical process control because I didn't really know when something was going to happen. And then the underlying characteristics describing statistical process control, they really lack a gold standard, but I think it was a fair assessment to sort of take it and compare it to the visualization method. And as for future work, I think implementing this, trying to implement this prospectively would go a long way to helping us with our clinical decision support work, and then exploring methods for sort of tracking the attribute changes automatically rather than having a sort of blast notification system. So just to revisit what I hope were the research objectives, which maybe I achieved. So one was to determine whether there were clinical decision support malfunctionings occurring in the commercial EHR. I did find there were 4 confirmed ones and 9 unclassified ones. And then the pathways, we described those and went through those in excruciating detail. And then I talked about the methods of detection and prevention. So just in conclusion, a total of 226 alerts, 8,300 alert months, 4 confirmed malfunctions, 9 unclassified anomalies, which make me nervous. All the malfunctions are knowledge related, and statistical process control augmented with visualization is a promising method for CDS malfunction detection. So I want to thank Dave, who's my committee chair, Dr. Yackel and Gorman, Adam Wright, who's been very helpful with the work I've done, Denise Sandell, Diana Pennington, and Neil Adio, who have all been very helpful on some of the validation stuff. And then obviously want to thank Dr. Hirsch for the opportunity to be here in total in the training grant, and Virginia, who's been a very, very helpful resource and friend. Thank you very much, Virginia. Alfredo for always being funny. Rory sits next to me, which is probably bad for her because I always have lots of questions or, hey, take a look at this. But I always appreciated her. She's always willing to lend an ear, and all the fellows and staff. So thank you, everybody, very much. Dion had her hand up first.
Go ahead.
Okay, very nice presentation, Dr. But how are you going to explain to President Trump that this is important work and needs to be funded?
So I think the reality is it probably the way that the healthcare payments are changing, it's not really anything you need to explain to anyone except yourself. So I think most of the organizations, as you move away from fee-for-service and things are more focused on value, the need to be able to sort of have a better handle on what your sort of quality improvement initiatives and what your clinical decision support is, that stuff's really going to inform your, essentially, your reimbursements going into the future. So, but you can try to explain it to me if you want. Yeah. No, that's you, Bill.
Oh,
yeah. Sorry.
Well, actually, there's a question from Shannon on the Twitter server. It's actually similar to Shannon's question is, how do we proceed future work without a gold standard? I guess my question was going to be, your numbers are relatively small, and so your system seems to have a more sensitive and specific bent, which is probably good if the anomalies detected are small, because you can deal with a small number of false positives. But what happens in the future, actually, when your office mate Rory starts coming up with all of these genomic guided clinical decision support, where all of a sudden the amount of clinical decision support increases, will these methods be scalable?
Yeah, so I think, the statistical process control, I think, is scalable, right? I mean, there's no reason you couldn't automate all of that. I think that, having to do visual reviews on it, I mean, I think the reality is the clinical decision support, it's a very resource-intensive process, and even if you're not spending a lot of time just looking at how well it actually performed, I mean, the reality is you need to actually find out if it did what you wanted, which is even sort of further along and is having the content be valid. So I think to sort of answer your question, I think the statistical process control is, and I think it probably can be applied to most of this cohort. I think alerts that aren't happening that much, and they never happen that much, I mean, I don't think you need to, you can sort of monitor those in a sort of, a kind of, sort of maybe just have a different threshold limit. You're not going to use statistical process control, but this alert never fires more than 10 times in a day or a week. And so I think, most of this could be handled by statistical process control.
Mm-hmm. What about a gold standard?
So lack of a gold standard, that's a tough one that I don't necessarily have a great answer to. I think the reality is for this, you can't, the resources just don't allow you to validate the whole cohort. But I think, as people spend more time actually looking at the CDS, I think figuring out what pathways and then being able to find out, additional pathways that maybe this method just doesn't pick up at all, right? There may be some pathways where, for whatever reason, the amount of alert firing is exactly the same and that doesn't change. So I don't, yeah.
I just had a comment, Steve. A really nice job. You've, I think, succeeded in helping us in the first step of change management. The first step is to admit you have a problem. And until you quantify the problem around clinical decision support in this way, people think it's probably functioning properly. What you've demonstrated is a way for us to identify how often it's not functioning properly, which I think the people that have been working in this area for a while know that it's broken all the time, or maybe more often than anybody wishes. Maybe all the time is a bit too far. So I don't know. Maybe Ross Koppel. Well, this will be his next area that he'll pick up on. But so I think you've just started to focus attention on an area that needs a lot more work. To Bill's point, there are going to be so many unanswered questions about this. How do you set it up? to properly study these, we don't know. Where are the best opportunities to try to reduce the errors in the future? We're not really sure. The first step is admitting that you have a problem, and I think these methods start to move us down the path of being able to quantify how often clinical decision support is, in fact, not doing what you think it's doing.
Oh.
So, sort of following on what Tom just said, Perrow, when he analyzed the 3 Mile Island accident, came up with a theory called normal accidents. He said when systems are so complex that you really can't understand them, and things are tightly coupled, then accidents are going to happen inevitably. And no two accidents will be the same. So I'm really nervous about 9 unclassified CDS anomalies that we can't figure out what they were. Do you think that aim here, should Tom invest his resources in prevention, and trying to improve processes so that CDS anomalies don't happen, or detection so that he can capture them before they lead to trouble?
Can he just take whatever pile of money he has and split it in half?
Well, so the pile is small, but but either way.
Yeah. I mean, is your question where do I think there's
Where
more?
do you think the money is in terms of trying to alleviate my fears?
If you ask me what I would want to focus most of my effort on, I'd actually want to focus more of it on prevention, because I think the reality is, I think a good portion of what you're seeing here is the fact that we birth these alerts, the egg cracks open, they get pushed out of the nest, and that's it. We let them fly, and no, there's not a lot of effort being done to go back and look at them. I think a lot of these you would find if you were trying to do prevention on them, right? So you would come across these normally if you just said, okay, we have a process, this alert, it's going to be revisited in 6 months' time. We're going to check to see if it's still guideline compliant. We're going to see how often people are overriding it. We're going to see how often it's firing. And I know that sort of it's prevention with a lot of sort of detection baked into it. But I think that having a tighter knowledge management process around, I think we're good at taking requests for alerts, creating the alerts, testing them. But I think then following that life cycle back up is where
Bringing
I
them
think
back to the nest.
back to the nest for a checkup.
So it worked. Okay. Thank you.
Very nice, thank you, very informative. I was wondering about the issue of the override.
Yeah.
So that, as I understand it, so the malfunctions are when the alert basically stops doing what you want it to do.
Yes.
But sort of complementary to that, it would be the whole issue of overrides. Like when it is working and say 99% of people are overriding it.
Yeah, so I mean the
override somehow wrong.
Right. So the overriding, I mean, it sort of is a kind of background for what I'm looking at. So I didn't necessarily look at it. Yeah, I mean, I think.
It seems like they would sort of go.
Yeah,
together,
no, I think so. I mean, I think at least in my mind, it's sort of like, if you're going to put CDS out there, you are obligated to make sure that it functions properly. And part of that functioning properly is making sure that it's actually useful to